Hi, I'm Dr. John with the Voyage Clinist podcast. Our mission with our podcast is to bring knowledge and education to our communities and our families. Today we have one of my favorite guests. I say that quite a bit, but she really is. Mrs. Alina Fong. She's amazing. She's a PhD neuropsychologist, and I want her to just kind of introduce herself and tell us about your credentials, tell us where you come from, and tell us where you're boarded and all that jazz.
All right. Well, thank you for the intro. My name is Alina K. Fong. My middle name is actually Kapahu Pineakalekoa.
Oh, let's go.
Yes. So if we're going to go there, I'm Native Hawaiian, born and raised in Hawaii, and did my education there. For those of you who may be familiar with Hawaii, I went to Kamehameha Schools, which is a private school for children of Native Hawaiian background, and was very fortunate to attend there and graduate there. I won't tell you the year because that'll date me, but I came here to Utah to do my undergraduate work, and it was there that I actually was able to, I came to BYU here in Provo, and I did my undergraduate, I did my master's, and my PhD. So my blood runs blue for BYU.
Blue indeed.
Yes, I am a cougar through and through. But I was really fortunate to be able to get my doctorate from an institution and study under some of the best in neuropsychology. Mm-hmm. So after that, I got my degree there. But I did my residency at the VA hospital in Salt Lake City.
Cool.
And it was actually right during the Iraq and Afghanistan wars. And for those of you who have loved ones.
Lots of TBIs, lots of head trauma.
Exactly.
Yep.
In fact, concussion was the signature injury of those wars because, and I talk about this a lot, but our gear and our protective gear had really advanced to the point where these guys were surviving all of these IED and RPG blasts, but they were coming home with these invisible injuries, which was a concussion.
Yeah. Well, today, if you haven't gleaned from what we're talking about, we're going to talk about concussion. We're going to talk about TBIs, post-concussion syndrome, and kind of rehabbing the brain and getting it back online and what that journey kind of is like. So, Alina, let's just break down concussion. Mm-hmm. Just break it down. There are multiple facets to it, multiple elements to it. It can happen from direct trauma. It can happen from indirect trauma, kind of a coup contra coup, they call it, like the brain is inside the skull, kind of rattling back and forth. Even with your seat belted, you didn't take a blow to the head. Right. You still end up with a concussion. Speak to it.
Okay, well, that was basically it in a nutshell. Let's shut it down. No, I'm kidding. No, it's so true. I think one of the things that I like to say, and I actually get this from my nurse practitioner, and it's funny because he said it so much that our front desk turned it into a shirt. They made it into a shirt. But he said, your brain is a consistency of warm butter. So when you think about that, right, for those of us who've had the opportunity to touch real brains, it really... It's so soft, it's so tender, and you can imagine, warm butter sitting on a counter for days. That is the consistency of your brain. So imagine that. It doesn't really take that much for there to be some sort of an injury to that brain. Yep. But the reason why concussions, I think, are so insidious and the reason why they're so misunderstood is because many of the patients that struggle with these symptoms look normal. They're not missing an eye. They're not missing an arm. They're not missing part of their brain. They look just like the rest of us. And so a lot of the damage and a lot of the injury and issues are happening neurometabolically inside the brain, okay? And even if you were to do an MRI or a CT, that would usually show up normal. So a lot of the injury is not necessarily structural, but it's an energy crisis. And it's evidenced when the brain is not using its energy correctly and efficiently.
I went to a continuing medical education conference a few years ago now, and you were one of the speakers, and that's where we met. And I remember you speaking about this concept, and I want you to just, for me, for our audience, just kind of break down that neurometabolic, that it's not utilizing its energy appropriately after post-concussion, after a concussion.
So plug, we met at the UOMA conference, Utah Osteopathic Medicine Conference, and I'm actually speaking at it tomorrow again.
Let's go.
Yeah, are you going to that?
I probably will.
Yeah, good. I'll see you there.
Yeah.
But let me break down in a very kind of simple way what's happening to the brain. So when the brain is involved in a concussion, okay, there is inflammation and swelling that occurs in the brain and at different points. Like you mentioned about coup contra coup injury. What that means is, let's say, that the brain kind of sloshed back and forth inside the skull. You may have a preponderance of injury maybe at the front of the brain and the back of the brain, right? So, just the laws of physics. So we have areas that are maybe a bit more swollen than other areas, a bit more inflamed than other areas. And what we find with our research is that the neurons in your brain, in order to fire, they do not have their own internal fuel source. So in order for brains to work and in order for all of your listeners to be listening and watching us right now, they need an ample supply of energy supplied to the neurons so the neurons can fire.
Yeah.
And that energy is actually in the form of glucose mainly and oxygen.
Yep.
Okay. So what we're seeing is a metabolic crisis where the brain is not getting enough of that energy to fire, or in some cases, there are some parts of the brain that are kind of gas guzzling and sucking up way too much energy and compensating for other areas in the brain that might have been swollen or injured during that time. And so it is truly a neurometabolic inefficiency or crisis that we're seeing with our patients. And we measure that using a type of neuroimaging called functional MRI.
Yeah. We have clinical tools, diagnostic tools, and often I see like lots of kids, lots of athletes, lots of soccer players, football players, rugby players. I played all those sports too, and I know what it's like to get your bell rung and the symptoms that you experience afterwards. Let's go through some of those. So sometimes you can enter like a heightened emotional state. You could be crying easily, really angry really easily. People can get confused. They can have some visual changes. Nausea is very, very common. Headaches, sensitivity to light and sound are very common post-concussion. Anything else that you can think of with post-concussion type symptomatology? I mean, those are the big ones that we kind of look for. And then if there are one kid, oh man, this was tough. He's a football player and he wasn't playing football. So some of our high schoolers, they like to have these little get-togethers, and they pull out their boxing gloves and they go out on like asphalt and they just throw haymakers at each other. They call it like fight nights or whatever. And so one of my patients was doing this, and he got hit just right in the jaw, and he went immediately. He got knocked out. I saw the video of him getting knocked out, and he hit the ground after he got knocked out. So he got knocked out, and then he hit his head on the ground. I was able to get out there and assess him within an hour. I mean, most of my clients have my cell phone and stuff like that. And so they called me, and I said, whoa, I got to check this kid out. And he was interesting. He was very, very emotional. His dad, this kid is a footballer. He's a big 6'3", huge guy. But his dad was BYU football player, so he's even bigger. Luckily, because this kid was almost uncontrollable. He was out of his mind. And he was stuck in about a 30-second mental loop. He would say the same thing, the same thing, the same thing, the same thing. And then he would repeat that, and he would just go over and over. And then he would have moments of like calm, and then he'd get really agitated, and then he was stuck in that loop. And that was, one of the more severe concussion symptomatology-wise that I've seen. Usually, you flash a light, you get your bell rung, you're a little bit shaken up, you might have some photophobia, and then headache for a little bit, and then you get better. I've had a gazillion concussions in high school football. Like we played 8-man football, and we just ran the ball all the time. And I was halfback, and then I was middle linebacker, and then I was receiving the ball, and then I was kicking off. So I was always running into somebody really hard. And then rugby in college.
That explains a lot.
It really does. It really does. And then rugby in college, I was like flanker. Yeah, these Polynesians, they're genetic cheaters coming off the pack, 300 pounds. They can move like, I'm like, how are you moving like that? You're like a huge giant. And there I am getting another concussion. So I think that's kind of the breakdown of the athletic space with like concussions. A very large percentage of the time, I would say concussions get better, right? They get better just with activities of daily life, like let's stimulate the brain, let's keep eating, let's keep doing your thing. Right now, we have pretty strict protocols for athletes that get concussed. We have a return to play protocol that we do, which is very smart. I mean, when I was a kid, they were like 3 plays later, send you back in, you know. And now we're being more methodical about that. I think that's really smart. And so, I think, is there a time, however, when that concussion doesn't get better, or are there things that we can, let's first address what can we do post acute concussion to kind of aid in recovery from your standpoint, and then maybe optimize recovery. And then we'll talk about maybe like post-concussion syndrome, things that don't get better.
Sure. Before we do that, can we talk again, though, real quickly about symptoms? Because I think sometimes parents don't know what to look for. I think there's a lot of parents out there, and those of us, that are experiencing the concussion ourselves, there's still some fallacies that are swimming around there about concussion that maybe we can clear up about that.
So let's do it.
One of the first things, and I'm glad that we're here to talk about it in this forum, but you don't have to have a loss of consciousness. You'd be surprised. There's still some doctors that I encounter that will say, well, it's not a concussion. This guy didn't lose any consciousness at all. And I'm like, my gosh.
That's a good point.
Right? Yeah. But we know, because we've been doing this, less than 10% of concussions that are documented, less than 10% have a loss of consciousness. So if you're waiting for that, you've already missed the mark. Okay. Yeah. So don't worry. Over 90% of these concussions never have a loss of consciousness. And there are four main symptom categories that I really want to talk about. Yeah. And I would just think of it like four main categories. Yeah. First is physical. So is your loved one or is your child having a headache? Are they having the light sensitivity? Are they having the noise sensitivity, the balance issues, things like that? That's physical. The second one is cognitive. So are they just not being able to focus like they used to? Do they have this brain fog that sits in? Are they more fatigued than they used to be? Kind of this just brain fatigue, okay? So there's cognitive. The third one is psychological, and that's where your patient kind of comes in, where they just were so emotionally dysregulated, right? Yep. So patients will usually experience either more irritability, emotional dysregulation. They just can't, control a lot of their emotions. It might be more sad, might be more crying, and they were not like this before. And then the last one is sleep. So that could be either too much sleep or too little sleep, having trouble falling asleep or even staying asleep. And so those are the four main: the physical, cognitive, emotional, and sleep. And most patients have symptoms in every category, but there's some other fallacies that I want to talk about with, like you said, what can we do acutely after a concussion? Yeah. Okay. Well, prior to about 10 years ago, right? He knows where I'm going to go with this.
I know it.
We were all taught to cocoon everyone. And by cocooning, we mean shut everything off, go into a dark room, do nothing until your symptoms get better.
Put them in a dark room.
Yes. That's what we were taught in school.
Yeah.
Okay. And that's what we told our patients. Well, it was about 12 years ago when I started Cognitive Effects, and I said, this is so wrong. All right. So one of the first things you need to do is get active. So I'm not saying, that there isn't a time and place for some rest, but what the guidelines state now, John, is no more than 24 to 48 hours of rest right after the concussion.
Yeah, I like it.
Yeah. So if you are now going over 48 hours and you're still not getting out of your room, you're not wanting to see anybody, if you stay in your room longer than that, you can actually be prolonging this. And so one of the best things you can do is get out, get a little active, get out in the sun, do a little 5-minute walk, okay? Yep. And just start socializing. Yeah. That doesn't mean go back to full-time work or anything after 48 hours, but just get out of your room and get active. One of the other things is what you said before, which is most concussions do get better. That's absolutely true. But what I would recommend and what I would say is that we should be seeing a doctor. I think one of the other fallacies is, if I just do nothing, it'll go away. Absolutely not. You need to go see Dr. Sanders. You need to go see, your doctor so they can monitor this. Because even though a lot of concussions get better on their own, if they don't, you want someone who's on your side saying, okay, let's not let this get worse. Go see a specialist.
Yeah. Yeah. I love what you said about go push the envelope of activity, both mental, physical, emotional, social. And I'll often tell folks, go out and do as much as you can until you can't anymore. You'll feel a sense of being overwhelmed. You might start crying. You might just get a really bad headache. You will feel that limit, and then rest, and then go rest, and then the next day you can do it again. Go out, do some stuff. Often kids are, they're going to school. They get overwhelmed. The vestibular ocular system, most commonly disrupted system after concussion, they have a hard time tracking, reading. It's just overwhelming. It's really difficult. And so I just tell them, do as much as you can. You still don't, it doesn't mean you don't do it. It just means you just push to the limit and then pause. Would you say you agree with that, or do you push past that limit a little bit? You push people. I love it. Any therapist is pushing people.
I do, John, Dr. Sanders, but I push them knowing what their brain MRI looks like. I know what their functional MRI looks like. I mean, so my clinic is Cognitive Effects, and we're here in Provo, and we specialize in functional MRI, and we do structural MRI, we do functional MRI, we do an MRI of the brain and the neck. My partner's a neurosurgeon, you know what I mean? So we know kind of how to push them and when to push hard and when not to push hard, but I will always err on the side of pushing.
Yeah. We often think of, like, after a shoulder injury, hey, we should maybe do some therapy on that. We should get the shoulder working better. And those therapists push those people. They're like cruel. And you talk to anybody who's done shoulder therapy, they know. They're like, this guy's a jerk. I hate them. I don't think we think enough of post-concussion brain rehabilitation. Like you should go for a few sessions, get some exercises, initiate some of those parts of your brain and get those things going again. We just don't think about that. I think your clinic is so innovative in that it does that. There are just a paucity of those clinics around.
Absolutely. There's an absolute dearth of clinics like mine, so much so that we're the only clinic in the world that does what we do. We literally have patients from all over this world and all over the country that fly into Little Provo, Utah, and do our 1 to 2 week treatment program here. And it's been such a, really just such a blessing to be able to have this location right here in Provo, right next to the mountain. We're right in Riverwoods, But I think, what's really important is that we need to really understand how significant these injuries are. Because I feel like with a lot of these concussions, there's just not enough of these kids that are actually going and seeking that treatment with someone like you. I really am going to push that because, like you said, with the shoulder issue, how much more complicated is your brain than your shoulder?
Right. You only got one. You got two shoulders. You can make do.
Right? I mean, I think we understand all the mechanics of how a shoulder works, right? But this brain is still so nebulous. And I mean, I think that's why I love neuroscience so much. It's because what I know today about neuroscience was not what I knew 5 years ago. The research in neuroscience is constantly changing as we're learning more and more about the brain. In fact, one of my favorite patients legit was a NASA scientist, PhD, and so he's an actual rocket scientist. And he said to me when we were going over his scans after treatment, he said, "I now know for sure that our brain is the most complex organism in our multiverse." Yeah. And that just gave me chills, and it still gives me chills to this day, because as complicated as the brain is, so many people don't go to a doctor when they get their brain injured. Yeah.
Well, and to your point, I think a lot of doctors, I mean, in our training, it's okay, you had a concussion, you'll be fine. Go push the envelope when you can't, pull back, and you should be fine. And about probably 80 to 90% of the time, that is true. We don't cocoon them down anymore. We get them out, we get them going, and they do make a reasonable recovery. Sometimes, however, there are small symptoms that continue, and then there are sometimes when there are profound symptoms that continue. And so let's go there. Let's talk about like that post-concussion syndrome space. What is post-concussion syndrome? Like after concussion, symptoms aren't getting better. Speak to it.
Okay, so the way you go from concussion to post-concussion is really not so much about symptoms as it is about time. That's all it is. So for you to be diagnosed with something called PCS or post-concussion syndrome or post-concussion symptoms. You just have to be struggling with some symptoms, for longer than 3 to 6 months. That's all it is, really. Now, when I say that, I mean, that doesn't mean it's simple. What that means is, you're right. There is a percentage of patients that for whatever reason, no matter what we do, they tend to have these symptoms that go long term. Now,
can we speak to those symptoms briefly?
Absolutely.
Okay.
Yeah. Now, real quickly though, if you are struggling more than 6 months with symptoms, you can actually be diagnosed with something called persistent post-concussion symptoms or syndrome, so PPCS. So what are those symptoms? Well, it could be anything, but most of the time when we look at, in fact, I know this because I'm preparing for my talk tomorrow, when we looked at about 5,000 of our CFX patients, we've treated about 6,500 now, but about 5,000 patients, we found that the top 3 symptoms were brain fog, mood and personality changes, and fatigue.
Yeah.
So I just want to, just clear up that one of the fallacies or one of the myths of concussion is, I'm going to be vomiting and nauseous and throwing up everywhere. Vomiting and nausea is like all the way down here at the fishtail end. Not a lot of patients will have that. But if you're still struggling with mood and personality changes, brain fog, fatigue, cognitive issues, those are some of the salient symptoms that tend to persist and last. Of course, vision and vestibular and ocular issues too.
I saw a lot of that, like just imbalance, like folks just still off just a little bit. That's really cool. Take us through what that looks like if you do have post-concussion syndrome. I've referred clients to you quite often, and I love what you do. Why is there such a dearth of clinics like yours? Why aren't more neuropsychologists going in and saying, let's do some cognitive rehabilitation post-concussion? To me, it seems like there should be a cognitive rehab clinic on every corner. We have so many concussions in America, right? Like is it the training? Is it physical therapists aren't really trained for it? They're kind of trained for the PT side of that, but not necessarily the cognitive rehab side of that. Like, why is there a dearth of this?
So what it always comes down to is money.
Sure.
Yeah. Truth be told, there is not a lot of insurance money in treating concussions. Yes, for acute concussions, but once a patient reaches that PCS or PPCS stage, right, where like I said, it's just about time, insurance companies don't want to reimburse for that. And so that's really what it boils down to.
Interesting.
It's always money, okay? Yeah. So the other piece of this too is that neuropsychologists as a whole are not focus a lot on the way the brain influences behavior and paper pencil testing. Okay. For those of you who have ever had to have a neuropsychological evaluation, I mean, it could be a 3 to 6 hour long test. Sometimes it can take 2 days. We're testing your IQ. We're testing your memory. We're testing your focus, attention. It's a really long battery, but it's paper pencil testing. Okay. And with this particular population, like I said, with the concussions, and not only do I see concussions, but we also focus on long COVID. Okay, I'm seeing patients with carbon monoxide poisoning, chemo brain, mini strokes, TIAs. So we tend to focus on the patients that are relatively high functioning or look like they're high functioning, right? Even their brain scans look normal, but on the functional MRI, they're really not, doing well at all. But the problem is that these patients look so normal. Okay, and so neuropsychologists, when you're trained to do these paper pencil tests, most of our patients would pass those with flying colors because those tests are actually meant for more severe stroke patients or neurotrauma rehab patients or neurotrauma ICU patients. Right. So that's the reason why there's not a lot of neuropsychologists that are comfortable in this field.
I see.
Okay.
I see.
But yeah, it comes down to really outside of the acute realm, there's not a lot of understanding or money or insurance that will cover a lot of these rehab therapies that these patients need.
Can you speak to what you guys do? What your innovation in that space is? I'd love for you to break down functional MRIs and how they kind of play a role here in your clinic. I think you're very innovative in your space. Speak to kind of your clinic and the innovation there. I love your shop. I think it's multi-dimensional. You have a healthcare professional, the nurse practitioner. You have physical therapists, occupational therapists. You have trainers. You have a whole neuropsychiatrist. You've got neuropsychologists. You've got neurosurgeon. You've got neurology. You've got a lot of different people there. A multi-pronged, faceted approach toward healing brains. Really cool. Speak to it.
Yeah. So we are a very unique clinic. And when I say very unique, I really do mean there's really no one else like this in the world, which is why we have so many patients coming from all over the U.S. and internationally. The reason why is really because we offer a type of neuroimaging that allows us to really see what's going on in the brain, even when structurally everything looks normal. So what I always say is there are 4 main reasons why patients choose us, because, they have to choose to come here, right? Sure. And they have to choose to come to Utah from all over, and they have to choose to give me 2 weeks of their life, because our program is a 2-week intensive program, and I'll talk about that. So the 4 main reasons why people end up choosing us. Number 1, we are the only clinic in the world that actually specializes in persistent post-concussion syndrome.
Right.
Okay, so we're not this acute clinic. There are other acute clinics, and I love that. And if someone comes to me and says, "Hey, I was just injured last month," I'll say, "No, go to Neural Effects. Go to IHC. Go to a more acute concussion clinic. Go to Dr. Sen. Go to your local doctor, but don't come to us." Okay, so we focus on the long term, not the acute patient. So that's number 1.
Okay.
Number 2, the functional MRI piece. And so let me talk about fMRI real quickly. So fMRI has been around for over 30 years. It's been used by neurosurgery for 3 decades at least. And what's really cool about fMRI is that it's looking at, in general, how your brain is metabolizing energy. So the MRI machine is a huge magnet. Imagine like this big donut-shaped magnet. For those of you who are listening who have ever been in an MRI, you know what I'm talking about, okay? But it is such a strong magnet that it can pick up on the subtle magnetic differences between oxygenated and deoxygenated hemoglobin. Okay, so oxygenated and deoxygenated blood. So, for example, remember when I said before that your neurons do not have their own internal fuel source? Neurons have to get energy from hemoglobin or blood.
Yep.
And so when you're doing a task while you're in the MRI machine, so we're going to have you do memory tasks, attention tasks, basically a neuropsychological test while you're in the MRI machine, we can actually see which structures are taking up oxygen in order to fire, and then leaving that hemoglobin deoxygenated. So that's what we're actually picking up, is this energy transfer in how the brain is utilizing resources when it's demanded to do something like to think, or to remember, or to find the right word, or to solve a problem. Okay, so even though the brain looks normal structurally, when we do a test like this, we can see, wow, that left anterior cingulate is working exponentially harder than the occipital gyri to do that task. That's interesting. It must be because that left anterior cingulate is, compensating for, maybe that occipital region was inflamed or swollen during that concussion. And now it's just dormant. So it's a really cool way to see what's really going on. And it's so validating to our patients who have gone from specialist to specialist to specialist and being told, well, your scans are normal, you should be done. Maybe it's psychological now. Okay, so that's another thing. We'll get there.
Sure. Okay,
so that's fMRI in a nutshell. The third reason people choose us is because, like you said, we have a huge team. When I say huge, I really mean we have MDs and PhDs. We have neuroradiology, neurosurgery. We have PhD neuropsychologists, PhD neuroscientists. And then we have physical therapists, neuromuscular therapists, occupational therapists, cognitive therapists, speech-language pathologists, neurointegration specialists, sensory motor specialists, and the list goes on and on. We have over a dozen different disciplines.
It's amazing.
But they're under one roof.
Yeah.
Because so many patients who struggle with this, they have to become their own quarterback, to use the football analogy that you so like. But, you have a brain injury, but then you're your own quarterback, having to go to PT over there and organize your OT over there and your vision therapy in that next town over there. And no one's talking to each other.
It's fragmented care. Yeah.
It is absolutely fragmented care. And the brain is not fragmented. That's not how the brain works. Mm-hmm. So we have everybody all under one roof, all talking to each other. And then the fourth reason is it's a very intensive program. Most of our patients are with us for 2 solid weeks, 8 hours a day, from like 8 to 4 or 9 to 5. And, that's where the magic happens.
Yeah. That's amazing. Fantastic outcomes. Would you say with your guys' program, you have a fair degree of success in helping people kind of pull through some of that?
You could say that. I mean, if you consider, I know it's funny because when I say this, it almost sounds not real. And I'll get to that. But we've actually done our own outcome studies, and our own outcome studies show that 90% of our patients, 90%, report a 63% reduction in symptoms after 1 week of treatment. Okay? Now, that's not 100%. I'm not some charlatan that's promising the world, but that's incredible.
That's
incredible,
that's
right?
Like incredible, yeah.
Now, in case you're thinking, well, that's their own data. Well, we had enough Dutch patients. So Dutch people are from the Netherlands, okay, Holland. And over the years, about 1/10 of our patient load comes from this tiny country called the Netherlands. We were getting so much notorious attention, that a Dutch Brain Foundation decided to study us, because they're like, why the heck are all of these patients coming to Utah and spending all their money in Utah and time in Utah? And so they actually conducted a multi-year study of our patients. They tracked about 61 patients over the course of about 3 years.
No way.
And this just came out in March.
Oh, cool.
And what they found was almost 80% of the patients that came reported a significant improvement in symptoms. And they're tracking these patients now at least 6 months and longer than 6 months out. And they found that as time went on, the symptom improvement got even better and even better.
Wow.
So that's an independent study, completely third party.
Yeah.
But yeah, it
Is it
works.
just because they ride a lot of bikes over there?
Oh my gosh.
Without helmets, because I've been over there and nobody wears a helmet and there's bikes everywhere.
It is a cultural thing. So there are more bikes than people in Amsterdam. Yeah. And it is a cultural thing where they just refuse to wear helmets. And in fact, there was this great kind of a parody or a skit that was done where these kind of newscasters were saying, they say that if you have a concussion, your quality of life goes down because you can't be social, you can't go to restaurants because there's just too much noise and light sensitivity and stimulation. But they said, if you wear a helmet, you're a social outcast, so you won't have friends anyway. So that was their whole thing, is that it doesn't matter if you have a concussion or not, because if you wear a helmet, nobody will want to be your friend. So it doesn't matter. And, but it just kind of shows how cultural it is there. And there's a lot of reasons why I think that patients come to us from the Netherlands, but that's a big one.
That's amazing. That's amazing. Well, that's super cool. I love innovative shops. Voyage Clinics is very innovative. Mm-hmm. We're trying to disrupt and do things differently. I love what you said about quarterbacking care and having like everybody under one roof. We have a similar thing with primary care. Like as a family doc, we're quarterbacking people's care among multiple specialists and trying to pull everything together and help that continuity of care not get dropped and help all that whole process go forward for people's healthcare. What else do you guys do over there? Are there some other cool services that you maybe have dabbled in a little bit?
Absolutely. And I do have to say, when I first met Dr. John, I was so impressed with what he was doing because he was kind of the first person, I think, especially in Utah County or in Utah, that did direct primary care. And the first second I heard about it, you got to admit, right, John, I signed up my entire company with you.
Yeah.
I really did. Yeah. I believed in it that much. And I said, this is an amazing service. And this is a future of healthcare. Because interestingly, at Cognitive Effects, I didn't realize that this is what it was called, but I was doing direct specialty care for going on 12 years now, right? And so, and what you're doing is direct primary care. And so I believed in it the minute I saw it. Okay. So with that being said, I just love what Dr. Sanders does. And I don't know if I can share this, but you're actually my doctor.
Yeah.
It's
really sweet. Thank you.
Anyway, and it's funny because I did ask him, I said, okay, be honest, am I your most high maintenance patient? And he said no, but I think he says that to everybody.
Top 3. Easy. I'm just kidding.
I know.
You're awesome.
Okay, but some of the other things that we do, so let me just kind of give you an overview. We are located here in Provo, right in the Riverwoods. It's called Cognitive FX. And if you want to find us, it's Cognitive FX, so the letter F and the letter X, USA.com. That is a clinic that I've been talking about that does the fMRI.
Yeah.
We've actually just started this program just a few weeks ago, actually, because of this big overlap with mood disorders and that mood and personality change with traumatic brain injury. We started to focus our efforts on this mood piece. And we have Utah's only fMRI-guided TMS, so Transcranial Magnetic Stimulation therapy. So this actually focuses on patients with depression, with OCD, with migraines, with some anxiety. This is a technique that was actually just FDA approved in November of last year. And what we do is a bit different from other TMS. So TMS has been around since about 2008.
Totally.
But the problem with other TMS is that you would have to do like 30 to 40 sessions, and it would take months, and it was a bit too much.
You're kind of shooting blind.
You were shooting blind, and you weren't being guided by neuronavigation or fMRI. But this is exciting. Just a few months ago, in November of 2023, the FDA approved what we call a SAINT program, or an accelerated interval TMS program, where we condense 30 to 40 sessions into just 5 days. And so this was actually, again, FDA approved, so it's completely safe. But we take patients right now with depression. Now, most of the time, these patients have to have failed out of at least 2 antidepressant medications. Yeah. But if we're being honest, there's not a lot of us that want medications anyway. Yeah. Who wants to be needing those types of medications? So these are for patients that don't want to take medications, maybe have failed out of medications. This is a 5-day program where you're with us all day and you're receiving 10 treatments a day.
Whoa.
So it's like a 1-week program. And we've started a few weeks ago, and the response rates and efficacy rates for this are through the roof, especially with functional MRI-guided TMS. Now, the reason why fMRI...
For depression specifically?
Yeah. The reason why fMRI is so much more useful is because we have the exact location of where to put these coils to know exactly where in the brain that we need to target.
So, again, like holistic-minded family doc, taking care of people, lots of people with depression. Therapy is a part of that equation. Social networks, pickleball,
mushroom foraging,
all very healthy. Meditation, mindfulness, all really great. Sometimes SSRIs, sometimes various things. If they've failed a couple, they're what we would call like complex depression or like failed depression with traditional therapy.
Yes.
And then that is
depression.
The treatment-resistant thing.
Yes.
So this is the indication for what you're talking about, where you're like, hey, now we've got some options. Because there are those people, I have several of these folks, and they've just not a lot of options for them. They're at wit's end. We've tried this, we've tried that, and they're still struggling. And I don't know that this is like a magnetic cure or magic magnetic cure, but maybe it is to some degree. Like if it can reverse some of that, and we can maybe take them off of some of these meds and then help them move along. Why? How does this work? Like what does this do?
So it actually works with magnets.
Yeah.
I like magnets for some reason, right? No, but really what it does is it sends very intense magnetic pulses into specific parts of the brain. So when it comes to depression, the area that's the most studied is the dorsolateral prefrontal cortex.
Dorsolateral prefrontal. So
right here.
somewhere
It's
like
actually right here. Yeah, it's actually right about here.
Yeah.
And the reason why fMRI is so valuable is because without it, people would just kind of assume, okay, your brain's about this size. We're going to guess it's about here. Okay, so then they'll put a coil there and they'll just start kind of zapping that brain. So really, in a nutshell, what's happening is we are trying to stimulate electrical response in that part of the brain, okay? But the reason why the fMRI-guided is better is because there's no guesswork. We know exactly where to target. And what we're finding and what all these studies are showing is that when you specifically target the dorsolateral prefrontal, that actually it can stimulate the part of the brain that is responsible for mood and interpreting and perception, okay? And what we're finding is that specifically for suicidal ideation.
Yeah.
Wow. Just to be clear, TMS has been used for decades, but it's been primarily used for inpatient suicidal patients.
Really? I didn't know that.
Oh, yeah.
Okay.
Yep. So now we're kind of branching out and saying, well, it can help with suicidal ideation, but it can actually help for patients with depression even without the suicidal ideation. And so, yes, it really is. It's a way, it has an excitatory and an inhibitory mechanism that allows us to change the brain without being invasive. So TMS is considered a non-invasive brain stimulation.
Wow. What kind of symptoms do people have after TMS treatment?
So the typical symptom could sometimes be headache,
Yeah.
And sometimes we've had some patients that felt like elation and energy. Some people feel a little tired and some people feel some headaches. But I would say that's probably the biggest one. There was in the past like a concern that, there were some studies that showed that TMS could increase seizures. That has so far now been kind of debunked. I mean, the seizure prevalence with TMS is 1 out of 10,000 patients. And usually it's because the coil was placed maybe on the motor cortex versus the dorsolateral prefrontal cortex, which is why it's so important to get guided neuronavigation.
Oh, okay.
Yeah. So those are the main side effects.
That's really cool.
I know.
That's super cool. Any role for that in like concussions? I guess if they have like some depression stuff maybe, but is there a role there? So
interestingly, the whole reason we actually wanted to do the TMS, first of all, was because there's a lot of research that shows that just 3-minute bursts, 3-minute what we call theta bursts of this pulse increases BDNF. BDNF stands for brain-derived neurotrophic factor. Yeah, which is directly correlated to neuroplasticity. And so we actually thought about this for some of our concussion patients that were with us for a couple weeks and still a little slow and not getting the excitatory response that we're wanting. And we're like, well, why don't we just zap them with just 3 minutes, And so, yes, I think there's a lot of implications for our concussion patients as well as our concussion patients that deal with some of the psychiatric components.
That's really cool. One of the things that we've offered this last year as well in our clinic is ketamine treatment for treatment-resistant depression and for suicidality, for PTSD. And again, it's that BDNF spike that is driving a lot of the neuroplasticity, right? An ability to change your mind and to change your thinking or to feel differently. And that's magical. Like neuroscience and neuropsych, I think, are totally different fields, but there's some similarities in there in that we're kind of like merging the two in clinical practice. Like
absolutely.
There's psychology going on, but there's also just structure stuff and there's chemical stuff with the BDNF spikes and things like this. And if we can modulate that and influence those in people's brains, that's pretty awesome. I didn't know that TMS does the BDNF spike as well. That's pretty cool.
It's really, really cool. The one thing, the caveat that I have to say about ketamine and even TMS is that there's a lot of clinics out there that I think are not using it as correctly as they should. The thing about ketamine is that even psilocybin. We're talking about mushrooms,
Yeah, BDNF spike with psilocybin as well.
It's huge. The one caveat with neuroscience that we have to make clear is that the ketamine and the psilocybin and these other types of chemicals, they really increase neuroplasticity. Now, what that means is that neuroplasticity doesn't automatically mean everything's great. No. Neuroplasticity just means that the brain is very suggestible.
Open.
Mm-hmm. And so the important thing, and this is what we tell our TMS patients, is in between each of these sessions, I don't want you to get on your phone and start scrolling Instagram because your brain is now so suggestible to change. But if you just go back in between these sessions and then go back to scrolling your Instagram, you're rewiring your brain to want that dopamine from the Instagram again.
Yeah.
So you have to be very mindful about what it is you do in between these sessions and what you do after ketamine and after psilocybin. And, so be very cognizant and mindful about what you choose to do directly after these treatments, because all the ketamine is doing is increasing that neuroplasticity and increasing your brain's ability to change and be suggestible.
You still have to do the work.
Yes.
We require our clients to be doing therapy or have one of our therapists working with them while they're doing ketamine. Excellent. Because for that purpose, exactly. I like what you said about being cognizant about your day-to-day, what you're doing with your phones and with your things. And there's just such a huge implication with our phones on our brains. And they're pulling our brains, they're inundating our brains with dopamine and largely in a probably non-positive, non-productive way. Super tricky. I like that. I like just at least making them aware of those spaces. And, your BDNFs are going to go up with these therapies. Be cognizant of that.
Yeah.
It's kind of like someone who starts, I don't know, growth hormones probably is not a good indication. But I often tell people that BDNF is like growth hormone for your muscles, but for your brain. It's going to create opportunity for growth. But if you don't actually work out, it's not going to do anything. You're just going to have some growth hormone float around in your body. It might cause other problems if you're actually doing growth hormone. I'm not suggesting growth hormone is safe or okay to use, but like testosterone, like there are folks doing things that are increasing potential for growth, and then they're not doing the work to make that growth happen. 100%. Same thing with these things.
That's 100% it. And you and I could do a whole other podcast on the effect of, these phones on young developing brains. I mean, John and I both have kids, right now, this kind of in the same age. My oldest is a sophomore in college. My youngest is now a 6th grader. And then I have a 10th grader. And I am that weird mom that doesn't let them have social media. I am that weird mom.
Gangster mom.
I am that tiger, gangster, weird Asian mom. I get it. But I know they'll thank me later. Right? They'll thank me later. But, my 19-year-old now, I don't have control over that. So but I do realize that I think my children have less dependence on their phones than other children their same age. And we can talk all about that, but it really is affecting how their brains are developing.
Let's go into that at another podcast because I really want to dive into that. I think that would be super, super good. I make excuses to ground my teenagers off of their phones all the time. My son is currently, I have his phone in my pocket, and it's just what it is. I'm like, great, now you're grounded again. Too bad. I'm just helping you out, kid. That's wonderful. Thank you so much for this podcast. I think, talking in summary, just concussion, post-concussion syndrome, and then innovative treatments that you guys offer at Cognitive FX. Thanks for popping in your plugs. I was hoping you would do some of that stuff. That's really good. And then TMS and some of those, especially functional MRI-guided TMS. That's next level, right? That's not just a guessing game and a point and shoot and hope for the best. This is kind of next level goodness, and super cool that you guys are set up for that. But then you're also nimble enough to be innovative. Like if we wait for insurance or we wait for government or we wait for all these things, there will never be innovation, and it's just gonna it's gonna take forever.
Can I add one more plug too? Yeah. Where we see TMS really burgeoning is in the postpartum depression space.
Really? Okay.
Yeah, just because postpartum, you don't want to take anything. You have this baby, you're breastfeeding. And if we can get these moms in and do a week and they can have their baby and they can breastfeed in between. But we can give these moms some relief that's not invasive and won't affect the baby. In fact, we are working on some grant funding from the government to be able to run some pilot studies on that. So just so you know, if we always support each other. CFX, Neural Effects, and Voyage. Dr. Sanders and I have worked together for years, and we love to share patients. And so there's always, a pathway for your patients to come to us at a better rate as well, to benefit everybody.
Yeah. I appreciate that. Well, again, thank you so much. This has been really fun. Dr. Fong, you're super smart, and it's always fun to be in the presence of brilliance. So thank you so much.
Oh, gosh.
To our listeners out there, thank you so much for tuning in. Like and subscribe. And thanks again. I hope you learned some cool stuff, and we'll just keep on trucking.